denk dat je niet zo vreselijk veel macht hebt om dingen anders te laten gaan. Het gebeurt gewoon.
Maar ja, ik ben wel blij dat ik gewoon nog leef natuurlijk.
On voit l'être aimé, complètement distordu et il est là, il est plus là, mais en même temps il est là.
Quando hai alle spalle un dolore, una sofferenza del genere, apprezzi anche le piccole cose. Non è scontato niente, non è scontato che respiri, non è scontato che stai in piedi e cammini, puoi correre, non è scontato vedere il sole, non è scontato niente.
Bijna verdwaasd rond, in een trance rond. Maar ik moet zeggen, de zorg eromheen is wel heel erg goed. En ja, het was een heftige tijd, maar wel een mooie tijd.
Welke gevoelens ik heb ervaren. Ja, je bent ontzettend nauw betrokken bij mijn vrouw, wat die meemaakt. En je kunt daar niks mee, maar je moet er zelf mee uit de voeten. En je hebt wel het volle vertrouwen, dat had ik wel steeds.
Io sono un medico di terapia intensiva, non un rianimatore, nel senso che lavoro con i neonati, quindi mi occupo di tutt'altra di bambini molto molto piccoli, non faccio il loro stesso lavoro, però chiaramente il rapporto con i medici è stato condizionato anche dalla mia posizione. Tra l'altro sono dei colleghi perché sono nel mio stesso, quindi da una parte ero sicuramente facilitata nel comprendere razionalmente quello che stava succedendo, cioè non avevo bisogno dei lunghissimi colloqui perché mi spiegassero per avere notizie cliniche, perché era più semplice riassumermi le cose. D'altra parte, dal punto di vista umano, dal punto di vista emotivo, questo non è servito a niente, anzi forse ha peggiorato le cose, perché sapevo cosa poteva succedere e non volevo accettarlo.
Ahora lo que me motiva es mejorar la vida de la gente. Ya no es tanto la técnica, ¿no?, como cuando eres joven, porque llega un punto que la técnica es técnica y no tiene ningún secreto, sino las pequeñas cosas que pueden hacer que marcan la diferencia. El hablar con el paciente, con la familia, el hacer una educación sanitaria que nadie ha hecho hasta ese punto y tú no lo sabías porque dabas por hecho que lo habían hecho. Esas cosas son las que te motivan, el mejorar el cuidado del paciente.
Il faut faire du cas par cas, en fait. C'est primordial. Parce que chaque histoire est différente. Et quand vous vous trouvez en tant que patient, en tant que famille de patients, dans cette situation, dans un univers où vous ne parlez pas cette langue-là, cette langue faite d'acronymes et de termes techniques que vous ne connaissez pas, quand vous vous retrouvez face au savoir et que du coup vous vous retrouvez impuissant, que vous vous retrouvez stupide, que vous vous retrouvez humilié, que vous vous retrouvez démuni, comment faire?
Jokainen lääkäri varmaan pelkää komplikaatiota tai jotakin, että mitään ei niin kuin ei hiffaa jotain juttua, mitä olisi pitänyt hiffata, joskin siinäkin auttaa se, että harvoin tekee yksin koko päivää töitä. Nämä tuli nyt äkkiseltään mulle mieleen.
And what scares me is that making those decisions and making those wrong decisions and the realization that that decision in 3-4 weeks' time, where you end up having a patient who in effect can be crippled by life-sustaining therapy, which may not have been in their best interests or their family's best interests. And that still scares me. And I think it scares a lot of colleagues, but intensive care is much more multidisciplinary now, and I think that has helped our decision-making and has reduced that fear factor.
Honesty and humility go a long way. And most patients and relatives understand that we're also human and mistakes can happen and should be openly discussed.
Οι ασθενείς όμως έρχονται σε επαφή με εμάς, ιδιαίτερα αυτοί που βγαίνουν από το νοσοκομείο, πηγαίνουν σε κέντρα αποκατάστασης και ύστερα από πάρα πολύ καιρό έρχονται να μας συναντήσουν, γιατί ξέρουν τα πρόσωπά μας, τις φωνές μας, τον αγώνα που δίνουμε μέσα στο χώρο για να καταφέρουμε να τους σώσουμε, να επιβιώσουν και έρχονται να μας δουν, να μας γνωρίσουν από κοντά, να τους δούμε κι εμείς.
Together with my colleagues, in particular the nursing colleagues, we arranged a wedding for a patient who was at the end of his life and had decided to marry his long-term partner before he later died. And it was very moving to be part of this very special event in the intensive care unit.
It's a real privilege to be able to support a patient and their family through that what I hope is the worst thing that ever happens to them in their lives, to be able to support them through that, hopefully to recovery, or to support them through managing a dignified death.
Il faut ramener la vie. Pourquoi est-ce que tout est si blanc et voire gris? Pourquoi est-ce que ce lino couine autant sous les crocs des médecins? C'est insoutenable. Pourquoi est-ce que tout était autant aseptisé? C'est pas 3 photos qui vont empêcher les gens de travailler. Moi, je pense que c'est important de ramener de la vie à cet endroit où on se trouve à la frontière au bord d'eux, on se trouve dans une espèce de no man's land où on sait pas sur quoi ça va déboucher, quoi.
La mia opinione della terapia intensiva è fantastica perché mi hanno salvato la vita e dopo 3 anni sono qui. Anche a un altro ospedale che mi hanno dato per morto, per fortuna sono arrivato a questa terapia intensiva e mi hanno salvato veramente la vita.
Solo belle cose possono uscire dalla mia bocca, ovviamente, perché senza di loro non sarei qui, ripeto, non sarei qui oggi.
Intensive care medicine allows me to learn something new every day. So every day I meet colleagues and I hear of their new technologies, new advances, and progress in their particular specialty. But most importantly, every day is a different day with new challenges, and I enjoy the interaction with my colleagues and most importantly with patients and their relatives. So it provides a great variety, it's different every day, and it's a specialty where progress is made on a regular basis.
Grazie perché mi hanno ricordato anche come si lavora. Cioè, io faccio questo mestiere, lo faccio da tanti anni, ci sono dei momenti in cui sei stanco, in cui hai le tue cose, nel senso che hai la tua vita, hai delle preoccupazioni, però io ero serena quando andavo via, non perché sapevo che non sarebbe morto, poteva morire, poteva star male, ma era nelle mani migliori. Sapevo che era nelle migliori mani e questo mi dava quel minimo di tranquillità che potevo cercare. È giusto che i bambini che mi vengono affidati e i genitori quando vanno a casa possono pensare la stessa cosa. Siamo nelle migliori mani, quindi dobbiamo sempre fare il meglio. Grazie a loro per esserlo il meglio.
Hello, everybody. Good afternoon, good morning, good evening. My name is Antoine Schneider, and I'm the newly elected chair of the acute kidney section of the ESICM. And I'm extremely happy to be chairing today a webinar organized by the society that will deal with acute kidney injury, and in particular with renal replacement therapy. So today we have two great speakers that will discuss the topic and shed lights on the new discoveries on renal replacement therapy. And we will start with the timing for initiation. So when we will initiate the therapy, going through the different major trials that have been published in this field in the recent years, published in very large journals, when to start, when to stop. And then we will discuss how to optimize the therapy and to deliver the best therapy to our patients. And so for the first part, I'm super happy to introduce Sean BAGSHAW. So as you probably all know, he's a professor in Alberta University, Edmonton, Canada. He's a very well-known researcher in the area of acute kidney injury, but he also focuses on ICU organization and vulnerable population. He's a very busy intensivist, as you can see, because he's actually on call today. So hopefully we will be able to have him for the whole duration of the symposium. Of course, he's mostly is very involved in the topic because he's the one of the two main lead authors of one of the major trials in the field of AKI, or renal replacement therapy. And right in the topic he will discuss, of course, I'm talking about the START AKI trial. So Sean, thanks for joining us today, and the floor is yours. Thank you.
Thanks very much, Antoine. And I'd like to take this opportunity to thank the ESICM AKI section for the invitation to participate in this symposium today. I have these disclosures for 2021. Whoops. So let's first begin with when to initiate renal replacement therapy. Existing clinical practice guidelines, of which three of the most prominent are sort of shown here, are now more than 10 years old and really don't make strong recommendations on when to start renal replacement therapy, likely due to the relatively weak and uncertain evidence base at the time of their publication. The statements included in all of these are clinically sensible, of course, and there's general agreement on initiation of renal replacement therapy when confronted with urgent or life-threatening complications. However, new trial evidence has clearly been published in the last few years, and it is likely that these clinical practice guidelines deserve to be updated. Let's review the rationale for why we might consider renal replacement therapy in ICU settings. There are certainly benefits and there are certainly risks. Renal replacement therapy will effectively address the first three benefits noted here. So part of the question really is whether addressing any one or all of these, so azotemic control, metabolic acid-base homeostasis, fluid balance homeostasis, among the others, in a given patient, plus the purported broader systemic effects, will translate into improved patient outcomes and efficient resource use. So as such, I think the decision to start must balance the relative benefits and risks in a given patient, in a given context, integrating all the available clinical information, and having an appreciation for the existing evidence base and literature. So to some extent, that translates into a somewhat of an individualized approach. What do we know about clinicians and their decision-making around starting renal replacement therapy? There have been several surveys and observational studies that have described clinical practice. And I would argue that the decision remains largely subjective. Clinicians do their best to integrate all available clinical information. So things like the patient reserve, resilience, the trajectory of illness, evolving indications. They integrate the existing evidence base and the availability of resources, of course. And I would submit that despite this, the decision about escalation to provide renal replacement therapy, just like other decisions for other organ support in ICU settings like mechanical ventilation, et cetera, still remains susceptible to clinician bias. So some general statements from this work would suggest that clinicians generally, when confronted with life-threatening or urgent indications, don't hesitate to initiate renal replacement therapy in a patient who is otherwise eligible. There seems to be wide variation in the minimum severity of indications prompting initiation of renal replacement therapy, and many other factors modify the decision. Patient-related factors such as age, multimorbidity, dynamic factors such as whether they respond to a diuretic challenge, overall acuity of illness and their trajectory of illness. And then there's non-patient related factors, so sort of organization of dialysis services, if you like, the consultant services and other logistics that do actually impact the initiation of renal replacement therapy. What about the existing evidence base? So this is a very nice individual patient data meta-analysis that was led by Stéphane Gaudry and colleagues in France. And it pooled the available data on 10 randomized controlled trials. So this was before the publication of the main phase of the START-AKI trial, and included about 2,100 patients, and really found no differences in short-term mortality between early and delayed strategies for initiation of renal replacement therapy. However, also showed that fewer patients in the delayed strategies actually received renal replacement therapy. However, there's probably some residual uncertainty across these trials, these 10 trials. And that's probably driven by nuanced differences in design, in the settings, in the case mix, in the eligibility criteria, and in the definitions for timing of the intervention, the early versus delayed. And as such, this is still likely contributed to some clinical uncertainty and variation in practice. So we hope that the multinational START-AKI trial, which I was privileged to be one of the co-PIs for, which randomized 2,927 patients to strategies of accelerated versus standard initiation of renal replacement therapy, would help resolve some of these lingering uncertainties for clinicians who are sort of confronted with this decision, and also perhaps work towards greater harmonization of practice. As you know, the key findings from START-AKI were that we found no difference in 90-day all-cause mortality. This was the primary endpoint. And this was robust in pre-specified adjusted subgroup analyses and analyses looking for heterogeneity and treatment effect. We also found that there was greater renal replacement therapy dependence at 90 days amongst those that were allocated to the accelerated strategy compared with the standard. And again, this was robust in pre-specified analyses that looked at inverse probability and multinomial regression with different disease states. It showed as well that there was greater rates of adverse events in the accelerated strategy compared with the standard. And this was driven largely by episodes of hemodynamic instability and hypophosphatemia. And then finally, we found that 38% of patients who were allocated to the standard strategy did not receive renal replacement therapy. So there's clearly differences in resource utilization between the two treatment arms. So as such, START-AKI appeared to reinforce the acceptability of a watch and wait strategy, whereby RRT would be initiated in response to conventional indications, either evolving or persisting, and clinician judgment. However, there also arose uncertainty about how long could renal replacement therapy be safely delayed, and could a strategy of even more delayed renal replacement therapy be acceptable, improve patient outcomes, or reduce further renal replacement therapy utilization? So this was the primary question asked by the multi-center French AKIKI 2 trial, also led by Stéphane Gaudry and colleagues, where 278 patients with severe AKI were randomized to delayed or more delayed renal replacement therapy initiation strategies. The delayed in this trial largely aligned with the delayed in the AKIKI 1 trial. The primary endpoint was renal replacement therapy free days, a composite of death and freedom from dialysis, which was interestingly not found to differ between these two groups. In pre-planned adjusted analysis, the more delayed strategy was associated with an 11% absolute difference in mortality. And I would argue this is a clinically important difference. And a greater adjusted hazards of death at 60 days, along with higher SAPS-2 score, greater acuity of illness, and the use of invasive mechanical ventilation in their modeling. So these observations provide insights into the notion that perhaps excessive delay to initiation of renal replacement therapy among patients with non-resolving AKI may in fact be harmful. And this may be potentially due to prolonged exposure of azotemia or excessive fluid accumulation or interventions that are used to mitigate the complications related to AKI. We're uncertain. But as such, I would suggest there still remains some uncertainty when to commence. And this was evident in START-AKI. So when we designed START-AKI, we wanted it to be pragmatic and real world. As such, we sought clinician equipoise as part of the eligibility criteria, recognizing and acknowledging the clinical uncertainty many clinicians have when confronted with the decision about when to initiate renal replacement therapy or not. We noted that a significant number of patients who were eligible for START-AKI ultimately were excluded due to a lack of individual clinician equipoise. And indeed, this represented about 89% of all exclusions of patients who had fulfilled provisional eligibility. We did collect some detailed or minimal data on these patients. So of these sort of 7,900 patients, 72% were excluded because clinicians mandated deferral of renal replacement therapy. We captured about half the data on these patients, and it showed that relatively few, only 11%, ultimately went on to receive renal replacement therapy, and their mortality was lowest, 24%, 25%. Alternatively, the remaining sort of 2,200 patients, we collected about a third of patient data on this cohort. And these were excluded because clinicians mandated immediate initiation of renal replacement therapy. And we showed that about 91% went on to receive renal replacement therapy, and their mortality was higher than the aggregate mortality in the trial overall. So you can see there's some difference. So clinicians probably had some confidence in some respects, but I would argue that these observations do imply a relatively wide uncertainty for predicting the clinical course of AKI and the likelihood of either imminent or early recovery or worsening or persisting AKI that would potentially prompt initiation of renal replacement therapy. So it would imply still there's a bit of a knowledge gap here in our clinical capacity to predict the course of AKI in a proportion of patients who have severe AKI in the ICU. So do we have new tools on the horizon that may aid in our decision-making for clinicians on when to commence renal replacement therapy? And recently, this prospective observational cohort study, the RUBY study, enrolled 364 critically ill patients within 36 hours of developing stage 2 to 3 AKI, and discovered and described a novel clinical biomarker, the urinary CC motif chemokine ligand 14, or CCL14, to predict the occurrence of persistent severe AKI, defined as stage 3 AKI occurring and persisting for greater than 72 hours. The primary endpoint here was severe persistent AKI, and secondary endpoints included a composite of death or dialysis at 90 days. So in the RUBY study, urinary CCL14 was found to have the best prediction of all biomarkers assessed for persistent severe AKI with an ROC of 0.83. Moreover, it actually showed evidence of enhancing the predictive ability over a baseline clinical model in logistic regression that included other variables like BMI, diabetes, non-renal Apache 2 score, AKI stage, and the trajectory of serum creatinine. So it took the AUC or the ROC from 0.83 to 0.89, respectively. Finally, the occurrence of the secondary endpoint, RRT or death at 90 days, was greater, with greater increasing tertiles of urinary CCL14. So as such, the RUBY study provides some preliminary evidence that maybe this biomarker, CCL14, provides novel diagnostic and prognostic information for clinicians to aid in clinical decision-making, such as the timing of initiation of renal replacement therapy. But clearly, the findings necessitated further validation. And we recently reported this, a secondary external validation, in a secondary analysis of the SAPPHIRE study, the multinational SAPPHIRE study of 195 critically ill patients with stage 2 AKI. Again, the primary endpoint was persistent severe AKI, similarly defined, and the secondary endpoint was a composite of RRT and or death. And here you can see the ROC for CCL14 in our study to predict persistent severe AKI was 0.81 in SAPPHIRE, and that was very similar to what was found in RUBY at 0.83. You can also see in the figure on the right that we further confirmed that higher tertiles of CCL14 portended greater risk of the secondary composite endpoint of RRT or death at 90 days. We also recently published this algorithm, kind of an updated algorithm really, to provide some guidance to clinicians on thinking and decision-making around considerations for initiation of renal replacement therapy. Due to time, I'm not going to go through it in detail, but at present, we're not certain whether the precise role of additional clinical prediction scores or biomarkers such as CCL14 or other dynamic tests like furosemide stress tests, etc., what the role may be in an algorithm such as this for deciding on whether there's probability of greater benefit relative to risk for starting renal replacement therapy in a given patient at a given moment in time. Certainly, clinician judgment is always going to be a role here in deciding when to initiate renal replacement therapy, and I think this will be the focus of additional trials coming down the pipeline. So the decision to start renal replacement therapy is complex, represents a significant escalation in support, and can be influenced by many factors as mentioned. There has been wide variation in practice, and this has been driven by further variation in individual clinician equipoise, as shown in START-AKI. Recent large trials, large RCTs, suggest no benefit to an early or accelerated strategy to initiation of renal replacement therapy, and reinforce that a watch and wait approach is acceptable. But future randomized trials really need to integrate these additional measures that may help elevate or inform diagnostic certainty and clinical decision-making. Okay, let's move on and discuss renal replacement therapy discontinuation. So I'll bookend Silvia's discussion of what to do in the middle. Most recent clinical practice guidelines also don't provide strong recommendations or guidance on when the ideal time may be to wean or withhold renal replacement therapy in anticipation of recovery, as you can see here. What is apparent is that this issue, weaning or discontinuation of renal replacement therapy, has received relatively little attention in the literature. And this talk will not specify on when to transition between modalities amongst patients going from continuous to intermittent modalities per se. But one approach that you might consider to understanding when to ideally wean or have a trial of discontinuation is to ask whether intrinsic kidney capacity is sufficient to meet current demand, recognizing that both of these may be highly dynamic over time. Unfortunately, we don't really have a simple process or test to understand instantaneous kidney capacity and the relative balance with current demand. So we know, though, that failure to wean or the need for early reinitiation of renal replacement therapy after a trial of discontinuation is clearly associated with a higher risk of in-hospital mortality. And these are data from the BEST kidney study. But this study doesn't really provide us otherwise with insight into whether failed liberation or reinitiation per se is associated with incremental risk for further non-recovery of function and RRT dependence over time. I guess my approach really in determining whether a patient may be suitable for a trial of renal replacement therapy discontinuation involves, some simple principles. And I would say, is there evidence of clinical stabilization and readiness for de-escalation of support? Is there resolution and stabilization of the precipitating event? Has there been a reduction in the overall acuity and improvement of multi-organ dysfunction? Do the kidneys show evidence of increasing capacity, urine output or clearance of metabolic waste? Are the kidneys capable of managing the obligatory fluid requirements that go with day-to-day ICU care, or capable of managing the acid-base and metabolic homeostasis? Or has there been a change in goals of care, and is there being consideration for withdrawal of life-sustaining therapy? I think those are all sort of questions that I ask in my mind when I'm contemplating a decision about a trial of weaning renal replacement therapy. If we were to scan the literature for clinical factors that help us predict whether a patient will successfully wean or not, 4 factors really sort of bubble to the surface. And I would say that older age, greater severity of organ dysfunction and failure, lower urine output, and a longer duration of renal replacement therapy, all are factors that seem to consistently predict patients who are less likely to wean from renal replacement therapy at a given moment in time. I do think it's also really important for us to recognize as clinicians who prescribe renal replacement therapy that the prescription and the delivered renal replacement therapy itself can potentially modify the timing of recovery and liberation from renal replacement therapy. So there's evidence to support this notion, and this is a secondary analysis from the ATN trial where more intensive compared with less intensive renal replacement therapy prescription through 7 days, or at least patients who survived through 7 days, showed association with lower urine outputs and greater declines in urine outputs over time, despite similar, average ultrafiltration and even a net negative fluid balance amongst those in the less intensive group. Similarly, this is another secondary analysis from the ATN trial that focused on the 246 patients who were treated with intensive versus less intensive intermittent hemodialysis only. And this analysis found that those that received the more intensive renal replacement therapy had fewer renal replacement therapy free days through 28 days and had close to a 50% lower likelihood of kidney recovery at 28 days, defined as freedom from RRT with at least a creatinine clearance greater than 20 mils per minute. There's probably some indirect evidence to support this general hypothesis as well in the START-AKI trial. So as mentioned, we found that the accelerated strategy was associated with increased risk for kidney non-recovery and RRT dependence at 90 days amongst survivors when compared with the standard strategy. Moreover, again, we found that adverse events occurred with greater frequency amongst those in the accelerated strategy. And most of these adverse events were driven by greater occurrences of episodes of hypotension, or if you like, intradialytic hypotension. And this enables speculation that IHD events may be an important mechanism that contribute to kidney non-recovery and persistent need for renal replacement therapy over time. And I use this phrase coined by my good friend and co-PI in START-AKI called dialysis-induced kidney injury, or DICKI. I think it's going to catch on. In the end, I think it's worth emphasizing that how we prescribe renal replacement therapy, and hopefully Silvia will give us some insights into this, can contribute potentially to harm by potentially disrupting kidney repair and and propagating kidney injury and need for ongoing renal replacement therapy. There are a number of other studies that have looked at a series of diagnostic measures that may provide additional insights into whether kidney recovery is occurring, whether intrinsic kidney function is increasing, and whether a trial of RRT independence is warranted. And some of these include, measurements of daily urinary urea excretion, timed creatinine clearance 2, 4, 8 hours between sessions, measurements of daily urinary creatinine concentrations, use of kinetic GFR, and ideally this would mandate you measuring serum creatinine more frequently, furosemide challenges, and maybe some selected, evidence on biomarkers. However, by far the most evaluated bedside clinical parameter is urine output. This recent systematic review, urine output had the sort of modest sensitivity and specificity for predicting successful liberation from renal replacement therapy, but general thresholds of around 500 mils per 24 hours in diuretic naive patients seem like a minimum for consideration of whether a patient may successfully liberate from renal replacement therapy. So final thoughts, appropriate liberation from RRT is critical to minimize exposure to perhaps prolonged and unnecessary renal replacement therapy and reduce resource use, but also probably for patient selected endpoints. Selected clinical parameters may help target patients for who's ready for a weaning trial, so restoration of urine output and possibly other measures of clearance, so timed creatinine clearance or urea excretion or kinetic GFR, et cetera. Studies looking at this, though, have generally been small, and there's certainly a paucity of randomized trials. And we're uncertain about the role of biomarkers, but they're promising, and maybe they'll provide incremental value, but additional work is needed. So with that, I'll conclude, and I will thank the ESICM again for the opportunity to speak today.
Thank you very much, Sean, for this very comprehensive discussion and great talk. Thank you very much. We have time for the questions at the end of the session. We will combine the discussion of the two presentations. And I will suggest that you ask your questions via the chat on the ESICM TV. I will have access to these questions and I can ask them to the speakers at the end. So now we've discussed when to start and when to stop. So our next topic is how to perform optimized renal replacement therapy. And for this, I'm really happy to present Silvia De Rosa from Vicenza, Italy. Silvia is a clinical researcher in acute kidney injury. She works in the International Research Institute of Vicenza. She's also a representative of the next committee, and it's great to have her today with us to discuss the optimized renal replacement therapy. Thank you very much, Silvia.
Thank you, Antoine. So, as we know, acute kidney injury is a clinical syndrome that is characterized by impairment of kidney function. As we know, since 2012, we have KDIGO guidelines that combine rifle hacking criteria and based on serum creatinine and a urinary output. And these definitions are not immutable, and new definitions concerning the duration AKI have recently been addressed as observed by the proposed definition for transient and persistent acute kidney injury. But the incidence of AKI is increasing probably because people are using in their clinical practice diagnostic criteria and at the same time biomarkers, but also there is an increased awareness. And what KDIGO guidelines tell us is that we have to initiate RT emergently when life-threatening changes in fluid, electrolyte, and acid-base balance exist. And when making the decision to start RT, we have to consider the broader clinical context and the trends of laboratory tests. So they suggest to start CRRT for hemodynamically unstable patients, and for patients with acute brain injury, other causes of increased intracranial pressure or generalized brain edema, because CRRT allows slow, gradual, and continuous fluid removal and solute clearance. So if we want to achieve a successful CRRT, we have to focus on prescription and achieved doses, but also on treatment duration, type of dialyzer and method, but also dose of anticoagulation. But first of all, we need a well-trained medical and nursing staff with a well-established protocol. So I described such as steps to optimize CRT, and first of all, we have modality. The optimal approach to RT management and the selection modality are still uncontroversial, but we know that we have a modality that is RT components, and also we want to achieve ideal modality. To do that, we need to consider that the ideal modality is something that can give to us homeostasis preservation, improvement of the underlying condition, should be easy to use, inexpensive, and require less workload. But the optimal modality remains still unclear. What we know is that our critical ill patients are unstable patients, so probably CRT could be better. And also we need probably a treatment for 24 hours. So the difference is based on duration therapy, and consequently rapidity on net ultrafiltration and solute clearance also. So this is a survey. Is an old survey, but I think that is really important because it gives our information concerning practice, current practice and continuous renal replacement therapy, and show us how people use a different mode of CRT, and particularly 52.8% of people use at that time CVVH modality, and dilution site for replacement fluid was pre-dilution with 58.5%. But also CRT modality is not associated with outcome, and also there is no difference in mortality between intermittent and continuous renal replacement therapy. As we can see, we had a lot of several studies that they compare CVVH versus CVVHD, as this study is a multicenter open label parallel group pilot randomized trial in critically ill adult a patient with AKI and hemodynamic instability, and prescribed more solute clearance was 35 milliliter per kilo per hour, and the prescribed hourly ultrafiltration rate was increased above 35 milliliter per kilo per hour to compensate for the reduced efficiency of clearance related to the prefilter component of a replacement solution volume administered. And what they found was the SOFA tended to decline. Moreover, the first week in CVVH patients driven by reduction in vasopressure requirement and the concerning mortality and dialysis dependence in survivors at 60 days were similar. In this systematic review and meta-analysis focus on the effect of renal replacement therapy delivered as hemofiltration versus hemodialysis on clinical outcomes in patients with AKI, there was no effect of hemofiltration on mortality or other clinical outcomes, for example, RT dependencies in survivors, vasopressure use, organ dysfunction compared to hemodialysis, but data suggested that the hemofiltration increased clearance of medium to large molecules, including inflammatory cytokines, but meta-analysis were based on limited data. So current literature shows no clear superiority of dialysis modalities, and probably the selection of RT modality in adult ICU settings should be based on hemodynamic status, clinical condition, but also local expertise and also availability of staff and resources. What is emerging evidence is that CRT probably may be associated with an incidence of long-term dialysis independence. At the same time, we need also a randomized control trial focus on follow-up and in order to assess the effect of dialysis modality or renal outcomes. What we know that for similar reasons, CVVH appears to be associated with a shorter circular life than CVVHD, and for the same CRT dose, probably hemofiltration requires high blood flow that gives more flow limitation and more frequent stasis of blood flow. But in the same time, if you have to decide if we have to use pre-dilution, post-dilution, studies show that probably pre-dilution is something that is better for the circuit survival, but also for filter life. And also hemofiltration for a period of 24 hours could be cheaper to use in pre-dilution. So as shown in this systematic review meta-analysis focus on CRT circuits and reported filter life, CVVH confirmed that CVVH is associated with worse filter life, and also a majority of trials suggest a higher blood flow rate, increased filter life. However, probably it is unclear over what range this applies. So we need also study compare low and high flow blood are required. So in our clinical practice, in my clinical practice, what I do, so usually if my patients are hemodynamic unstable and require 24 hours therapy, I use CRT. When no longer requires CRT, I go straight on a hybrid therapy, and if my patient is ready to leave the ICU, probably there is a shift versus intermittent modality. So circuit life is important also because circuit life depends on insufficient anticoagulation. At the same time, we have patient-related factors, but also an increased treatment-related blood viscosity, or also altered blood flow mechanisms such as vascular access. The consequences are important because we can have a decreased dose and also an increased blood loss. In the same time, we can have alteration concerning medication. The fluid removal could be not consistent. We can have a lot of troubles because probably we are shifting from modality to the other modality, so we are changing set. In this case, we can increase the risk of infection, but also potential errors for the patients too, as a complication. So what we have to know is that reduced filter life is a reduced dialysis time. At the same time, we have a reduced dialysis dose and reduced ultrafiltration. So we have to focus our attention also on filter clotting because it could be associated with the blood loss, so we have to avoid a filter clotting, and at the same time we have to avoid the filter clogging, and to do that we can use pre-dilution because we can reduce protein adsorption. And we have also to be focused on filtration fraction because it should not exceed over 25. Also, the surface, the membrane that we use could have a larger surfaces and be relevant because it could be relevant for filter survival if we associate it with the CVVHD modality. We have to avoid downtime. 78% of downtime is due to filter clotting and reduced prescription delivery, and so we have to avoid the downtime over 8 hours because we want to maintain adequate the treatment shown in this study. In the same time, probably we can use a membrane with a graft, with heparin graft. Probably could be useful, but we have 2 randomized control trial that did not show any advantage in filter life. Hollow fiber membranes appear superior to flat plate membranes, but we have to study a lot on this because we cannot establish the advantage between membranes and the superiority regarding filter life. We know that we have factors with a negative association with the filter life, but the evidence is also very low. Anticoagulation is really close to circuit life. We have a bidirectional relationship, so we have to achieve optimal anticoagulation, but also the other point is to positioning at the same time a really right vascular access, and we will see later. So what we know is that when the blood is in contact with the foreign surfaces of the extracorporeal circuit, we have activation of both intrinsic and extrinsic pathway. This is important. Sometimes bioincompatibility reaction can be responsible, but it is more complex and is not well understood. What we know is that we can prevent clotting, and we can do that using pre-dilution, but also we can use different anticoagulants. For example, unfractionated and the low molecular weight heparin-coated membranes, but we just saw that we have low evidence concerning it, but also we can use regional citrate anticoagulation. So KDIGO guidelines recommend to use anticoagulation if patient does not have any increased bleeding risk. In the same time, if the patient is without an increased bleeding risk, they suggest to use regional citrate anticoagulation in CRRT. But if there is a contraindication for citrate, they suggest to use unfractionated or low molecular weight heparin rather than other anticoagulants. But they have side effects too. In particular, heparins have some disadvantages because increase the risk of hemorrhage, because heparin resistance and heparin-induced thrombocytopenia. But as shown in this study, the coagulation filter could be clearly dependent on the APTT values, and this could indicate a beneficial effect of heparin therapy on filter survival. But we know that the citrate give less bleeding because, as we can see in this study, had a significantly lower bleeding risk than the systemic heparin. So we have also a significantly reduced risk of circuit loss, but we can have also less transfusion and more extended life of the extracorporeal circuit. Another important component is a CRRT dose, because if we underdialyze the patient, we give to him the risk to high hospitalization, but also the risk of mortality. We have an important randomized control trial. And also, although the most appropriate dose has not been established for the majority of clinical conditions, large studies have demonstrated a direct relationship between dose and survival. In this study, the Professor Ronco studied 3 different doses, 20 milliliters per kilo per kilo, and also we have 20, 35, 45, and the first group, I mean 20, was significantly lower than the other groups, the survival. So KDIGO guidelines suggest that we have to deliver effluent volume of 20 milliliter per kilo per hour for CRRT in AKI, and these will usually require a higher prescription of effluent volume. So probably the best practice region should be between 20 and 40, but over 40, there is no benefit from this dose, as shown in Renal ATN trial. But also, in more intensity is not equal to improvement in mortality. We have also a side effect. For example, hypokalemia, hypophosphatemia, or higher antibiotic clearances. So more intensive was not found to have a favorable impact on mortality and also on kidney recovery. So we need more interventional studies to further assess the not selective convective clearance of cytokines in specific subpopulations, such as critical ill septic patients. Important is that probably we have a gap concerning delivered dose and prescribed dose, and also we have that there is a wide variation in the delivery of CRRT across centers, and there are limited data on validation of CRRT. Also, we know that the prescribed dose is dynamic, and we have to evaluate, to assess at least once every 24 hours and more often according to patient needs. So we know that also there is no evidence-based consensus in relation to which patients' weight to use, admission weight, either weight or current weight when determining CRRT dose. But it is recommended to use the current weight of the patients, as it theoretically accommodates acute increases in the volume of distribution due to fluid overload. In addition, there is no evidence to support that the average high-intensity CRRT dose can impact in a favorable way mortality or kidney recovery when compared to the standard CRRT dose. Delivery dose constitutes the trackable quality indicator that should probably be systematically monitored. We have vascular access is important because KDIGO guidelines suggest to use the right jugular vein because is the best option to insert on dialysis catheter. But at the same time, they suggest us to preserve the patient's vascular network in case of evolution to end-stage or renal disease. They recommend to use ultrasound guidance. They recommend to perform for internal jugular vein or subclavian dialysis catheter, I mean chest radiograph. But we know that probably the best catheter should be thick and short, and a more central position of the tip improves flow. Silicone catheter have thicker walls, so could be better. The holes are important because end holes the flow through the end holes is laminar, which is optimal, and the suctioning of side holes against the vessel walls may impair the flow. So probably the end holes are much better. In addition, we need that patient circulation is fine. So I mean that no low central venous pressure because it can affect the catheter flow. So as shown in this systematic review, tunnel cuff semi-permanent devices tend towards superior filter life compared to temporary device in each analysis, but we need more study to better understand which could be the best catheter. Concerning CRRT initiation and termination, just shown before. So I want to focus on team strategy because I think that this review suggests that suggests a good thing. So we have to quality control system, including 3 domains, structure, process, and outcome, based on quality indicators, and we need it because we need it to have a good lifespan, to have a good prescribed and delivered dose, particularly delivered dose. And at the same time, we have to decrease downtime period, and we can do just with the really trained people. So the team strategy is something really challenged, we know that, but it is important because if we want to perform in a better way our treatment. Also, if we are doing special treatment such as in septic shock, because we need also a really good training, and we need also we need the training, we need the device, and we know that there is no evidence enough to declare that could be suggested in our clinical practice as suggests surviving septic on pain. We have no evidence to suggest the using when there is no definitive indication for renal replacement therapy in patients with sepsis and septic shock. So our key points: the successful completion of our RT session is extremely dependent on the team's experience and the involvement of physicians and nurses. We need the registry because probably significant ongoing data collection is required to elucidate the optimal technological and management strategies to enhance current delivery. And thank you.
Thank you very much, Silvia, for this excellent presentation. We have several questions, and now we have a bit of time for a discussion. Received some questions from the chat, and I prompt you to ask further questions. Then I can ask our two speakers today. So the first question goes to Sean, and I would ask you. You've shown us that, of course, the overall the main study, of course, the main one was the START-AKR trial, has failed to demonstrate a benefit or early initiation in general for renal replacement therapy. But in the key trial, if you look at the subgroup of patients that eventually received renal replacement therapy, we know that those who actually received renal replacement therapy appear to benefit from early initiation, and the fact that only half the patients received the therapy in most of the studies, or 60% in the START-AKR trial, suggests also that the inclusion criteria perhaps were not ideal to identify patients who will receive renal replacement therapy. So do you think there is room for repeating these trials now that we have perhaps the furosemide stress test to identify patients maybe a bit better? You've discussed the CCL14. Do we have to start it all again?
Well, it's a good question, and you've it's a lot to unpack there, Antoine. So one of the issues that I think we rightfully identified in START-AKI in the pilot study is that it's difficult to override clinician judgment and exactly protocolize this, yes or no approach to initiation of renal replacement therapy, because there's a lot of elements at the bedside, characteristics of the patient, their evolution in critical illness, the response to interventions. A lot of those things are not simply captured by, a biomarker or a static, Apache 2 score, or, urine output in 6 hours or whatever. And so that really adds a layer of, intense complexity to this decision-making. And I think that was one of the strategies that we tried to circumvent by integrating the idea of equipoise into the eligibility criteria, right? So we recognize that some clinicians can identify a patient who's readily going to recover. And some clinicians probably are able to readily identify a patient who's clearly getting worse and it's clearly not going to recover in the next 24, 48, or 72 hours, just virtue of how they've responded to their initial resuscitation, the burden of organ dysfunction, et cetera. And so, on the margins, clinicians probably have a role to play here, independent of a lot of the sort of novel diagnostics and biomarkers. But in the middle, there's some uncertainty. And yes, it would be great to have some, well-validated, integrated tools that help sway the decision one way or another about the relative benefits versus the relative risks and harms of initiation of renal replacement therapy, right? I don't think it's ever going to be perfect. I think we have to think about probabilities and weigh that risk-benefit ratio. Do we have to do all the trials again? No, I don't think necessarily, but I think we probably have to do the trials, some additional trials to help discern, the best decision-making process around this. So integrating some of these, clinical decision support biomarkers or risk prediction scores or a dynamic test like an FST, which has been looked at in a small, pilot study and didn't really show much in terms of being able to discriminate, whether patients would or would not receive renal replacement therapy, right? So there is some uncertainty on this. And that's why I don't think we're ever going to be able to circumvent the clinician judgment side of it to some extent. And that's why we wanted to integrate that in the first place. I hope that gets to the question a little bit.
Sure, of course. The idea was also maybe to enrich the population before the inclusion of the trial with biomarkers or perhaps a furosemide.
Yeah, and just to add, we, as part of the protocol, even though it wasn't, intrinsic and necessary in the protocol, we recognize and acknowledge that clinicians have some genuine uncertainty. And that's what we wanted when patients were enrolled in START-AKI, remembering that it was an accelerated strategy. So, they were critically ill, they were on a ventilator for the most part, they were on vasoactive support and had at least stage 2 AKI. So some argue that, well, that's not a good enough discriminatory sort of, criteria to determine who would benefit from RRT or not. But the intent of START-AKI was really look at that advanced sort of accelerated approach to things. Does that improve patient-centered outcomes like mortality versus, what's probably done in many respects is a watch and wait strategy. And it didn't prove, that's the question, right? And so that's part of what I think needs to be appreciated as well.
Yeah. There's many questions for Silvia, and I guess it's because I only asked the viewers to ask the question then. So if you have more questions for Sean, I please ask you to ask your question in the chat now. I will get back to them. But otherwise, lots of very pragmatic questions for you, Silvia. You gave us lots of tricks. And maybe perhaps one more theoretical questions before we move to that. I know someone very close to you suggests that we should be replacing filters every 24 hours when we perform CRT. Is that something you do in your clinical practice?
Yes, because I work with them. Yes, we replace each 24 hours.
So then you don't have to worry about filter life because you change every 24 hours. Is that?
Yeah, is that once Claudio Ronco won it, and because he wants to decrease phenomenon clogging because he thinks about protein cake and he wants to replace the filter each 24 hours.
Yeah. Okay.
No way, because I want to use citrate, but.
Okay, because you didn't really mention citrate, and the main advantage, of course, is to move, to increase filter lifetime. But if you're going to change them,
but at the same time, probably he wants to use it because we do sequential extracorporeal therapy too. And if you start with citrate after 72 hours, you're sure to change the filter, no?
Yeah.
So it depends on clinical practice of expert centers.
Sure. Then there's questions from the audience regarding patients on chronic hemodialysis. Do your recommendation apply to them as well? And is there anything specific in terms of access, in terms of modality?
Yeah, probably yes. Chronic kidney disease. If a patient comes inside the ICU is because also has AKI, so we perform in our clinical practice CRRT, okay? And after we do a transition versus intermittent hemodialysis using heparin as anticoagulant.
And maybe that brings me back to Sean, because would that be a way, very pragmatic way of switching is switching back from CRT to IHD for those patients where you question whether he would recover the renal function sufficiently? It gives you time to prolong the time between sessions, see whether urine output comes back, returns, and maybe do every 1 day, every third day, etc., and have a way? Is that something that has been tested?
I mean, it's a good question, and as I said in my presentation, there is really a paucity of evidence about how to wean. If you think about how we wean a ventilator, Antoine, we dial back the FiO2, we transition from controlled modes to, spontaneous breathing, we diminish the amount of support. I mean, you wonder whether, something similar could be applied to determine whether somebody's, as you're transitioning, that's how I like to think of it anyway, you're transitioning some of the load and work to the actual native kidneys as their capacity increases to work, and showing evidence of that clinically at the bedside. And that maybe, help you in your decision-making around, an ultimate trial of liberation from renal replacement therapy. Patients who don't have that kind of capacity or don't show that kind of improvement, they're going to need to transition between the modalities as you awaken them, as you get them off ventilation, as you want to mobilize them. Over time, CRT becomes a little less practical. And so you have to think about that. And so I think you want to do it in a way that's going to minimize any iatrogenic, i.e. clinician prescribed and delivered renal replacement therapy that's going to propagate the persistent need for renal replacement therapy. And I think there's enough sort of evidence to suggest that that can play a role as well. So I think you want to transition, if you do, in such a way that you're going to minimize the, intradialytic hypotensive episodes, and you're going to minimize the other iatrogenic harm that occurs with that, so you can hopefully facilitate recovery.
Mm-hmm. Yeah, and so about modality, and the question I think was directed to Silvia, but you mentioned continuous versus intermittent, CVVH versus CVVHD, and one of the watcher has been asking about peritoneal peritoneal dialysis, which is something we don't do commonly in Europe, at least in adults. Are there any evidence that this is the ideal in terms of hemodynamics? What are your thoughts about that?
No, we don't use peritoneal dialysis. Probably is something that they're using in a low-income country when there is not availability concerning CRT. So in that case, it could be really helpful. Or probably if you have a chronic heart failure and you have acute on chronic, so it could be useful to use peritoneal dialysis. But in my experience, we don't use it. Is really because also when a patient comes in ICU and is in peritoneal dialysis, we don't use the catheter because could be could be with an infection, so we have to exclude it. So we prefer not to use it.
And I think that's a good point. I think in our practice here, we might consider its use only for patients who are already receiving peritoneal dialysis as an outpatient for their maintenance renal replacement therapy. Often those patients have some residual renal function to begin with anyway. And we might use it in the ICU for patients, but there are, practical considerations whether you can achieve sufficient sort of volume and azotemic homeostasis or not in patients who are hypercatabolic. And if they have a lot of lung injury and there are issues around ARDS and ventilator management, having the belly full of fluid can also have some bearing on intrapulmonary pressures and hemodynamics and stuff. So those are considerations. But there is certainly good evidence in low and middle income countries. A lot of it's come from Brazil that shows it can be used in acute kidney injury.
Yeah. Well, we're getting to the end of this webinar. I just have a few questions from the audience regarding nutrition. So maybe I'll ask the two of you in a short comment. What are your proposal, your suggestion on to how to feed patients while on CRT? Protein administration, vitamins, etc. Maybe Silvia, you can start, and then Sean.
Yes, you have to also to adequate the protein requirement. Usually we do 2 per kilo, okay, for proteins, and so you have to also to because the protein you can lose a lot of protein during CRT, okay? So it's something like a complication that you can have during extracorporeal treatment. And at the same time, the energy you have to consider if you are using citrate, because there is a calories that you have to consider when you are assessment the calories requirement for your patients, also lactate solution. And also vitamins, you have to replace it, of course, because you can lose during CRT.
Yeah, thank you. Any other comments, Sean, on the topic?
Well, same principles. I think you have to be cognizant of, how much protein and calories and micronutrients can actually be cleared with CRT, particularly patients who are on it for longer periods of time. And so, in our unit, in our multidisciplinary rounds, we certainly work closely with dietitians to help prescribe adequate calories and protein, 1.5 to 2 mils per kilo, as Silvia mentioned, and replace, essential vitamins and nutrients as necessary in CRT. So we try to augment and replace their nutrition accordingly. So.
Sure. Okay, so I think this brings us to the end of this webinar. So we've learned that acute kidney injury, of course, required sometimes renal replacement therapy, and Sean has depicted the recent randomized control trial evaluating the indication for the initiation, and also the criteria and things to consider when we want to win the patient from the machine and the therapy. Silvia has given us insight and practical tips on how to perform renal replacement therapy. I thank you both for these great talks and for this discussion, for helping and supporting the ESICM and the AKI section. It was great. Thank you very much. I thank everybody in the audience for the questions. I apologize, we didn't have time to cover all the aspects. There was lots of questions, but I'm sure the most were covered during this discussion. I also want to thank the ESICM for organizing this webinar and for the technical support. It was fantastic, and I wish you a good end of afternoon, good day for our Canadian, North American, or American friends that are watching us. And thank you very much, and see you at the following webinar. Bye-bye.
Thanks, Antoine. Thanks,
Bye.
ESICM.